Hey, everybody. I hope you're having a great afternoon. I hope your day has been good so far. Right now, I'm on here with a friend, Tyler Jones, who I'll let him introduce himself here in just a second. But this is going to be like a Q&A time. We're going to discuss some things. If you have any questions, please post them no matter where you're watching this on YouTube, Twitter, Facebook, Instagram, Dailymotion, or what have you. Please comment, ask us a question, and we'll ask it to Tyler here if you have any questions for him. And we're just kind of talking about what it looks like to be a pharmacist in the middle of COVID-19, in the middle of the pandemic, what the pharmaceutical industry looks like, maybe what even it looks like going forward from here, how things are changing. So please post and ask questions, and we'll definitely ask those questions here. But Tyler, I'll let you kind of introduce yourself.
Yeah, I realized I saw myself in the corner, my eyes got really big whenever you're talking about. I was like, I'm terrified just like everybody else. I do a good job masking it while I'm at work. So yeah, my name's Tyler. I've known Matthew for years. Probably since high school. So whenever he told me he was running down South Knoxville, I was really excited. Anything I can do to further the movement, push Tennessee left, I'm always going to be happy to do. But I'm from Knoxville. I went to UT for undergrad, and then I actually majored in political science there, and decided to go to pharmacy school. Went to ETSU in Johnson City, and I've been practicing for about 3 years now, and I'm the pharmacy manager at a food city up in Sevierville, right outside Gatlinburg. So been doing that I've been up there for a few months now, and really enjoying it. I've always liked working with rural populations. That's kind of why I got into pharmacy, and I've actually found through doing stuff like this, like having like a political science background has been shockingly helpful. Being a pharmacist, I actually worked with Mike Acosta at the Tennessee Pharmacist Association, a lobbying group up in Nashville for a month when I was in school, and also I worked with them throughout school, just working on legislative agenda stuff. So it's been rewarding to work on that type of stuff. And kind of combine my love / obsession with politics and scrolling through Twitter constantly, for better or worse, and pharmacy and healthcare. So yeah, I'm always happy to talk about stuff like that, especially right now.
Awesome. So what has over the past month and a half or so, how has being a pharmacist changed because of COVID-19?
So at first, this is more because I've talked to friends that work in hospitals. So I work in a retail setting, and I work in a grocery store. So for us, really, it was about 3 weeks ago whenever everybody was buying a lot of toilet paper. Everybody was joking about it, but that's literally all everybody was buying. And so for us, the big thing was we changed our hours, and so we've got we shortened the store hours a little bit so we can have time to stock and clean, and also we extended the pharmacy hours on Monday for our older patients, and it's all throughout the week in general. For anybody over the age of 65 or anybody with underlying health conditions can shop for about the first hour or two, and then they're welcome to come anytime, and anybody can, it's the honor system. We're not checking IDs at the door, almost like a reverse nightclub or something. So we're opening up for those people to come in early, and since then we've actually been working with Appalachian College of Pharmacy up in Grundy, Virginia. It's a really, really, really small town, actually, where the president of our company's from. They're compounding hand sanitizer for us. So they're making that and shipping it out to us, so where we're going to be able to get it for our patients. Other than that, the biggest challenge we've had has been lack of supplies. Whether it's almost something different every week. It's interesting to watch. It was. Oh, Lord, see, what was it at first? It was, face masks at first, then hand sanitizer, then isopropyl alcohol so people can make their own hand sanitizer. Then now it's thermometers and zinc, and Tylenol. That's the new stuff, because there's some studies out there that show that using ibuprofen for pain, if you have COVID-19, can possibly exacerbate the symptoms. So our Tylenol is pretty much out of stock. So we're out of a lot of stuff, and we're out of alcohol wipes too that diabetic patients use. So people go to check their blood sugar, they're not able to clean their skin before doing that, and it increases their risk. However small the increase is, it does still increase their risk of getting infections from just that puncture wound. So not having that stuff along with the stuff that I sell behind the counter, inhalers for asthmatic patients, inhalers, antibiotics, hydroxychloroquine or Plaquenil, which it's something before, because Matt and I talked on here before we jumped on live, and we were talking about it. And something that bothers me about this administration is that they keep calling it the anti-malarial drug, and I've been thinking about this a lot lately. And I think it's downplaying the importance of the drug to rheumatoid arthritis and lupus patients, because whenever you think anti-malarial, it's like malaria is not in the United States. It's fine. There's probably tons of the drug. But the thing is, that's whenever I think of those drugs, I think of them as for my RA patients and my lupus patients. So I think they're kind of minimizing the importance of that drug for those people. And so it's important to highlight that it is an anti-malarial drug, but what we use it for primarily now is immunosuppression in patients, and immunosuppressed patients are going to be the most vulnerable to getting COVID-19, but also, getting complications and it turning more serious because of those.
So have you started to see shortages in supply in this region of like hydroxychloroquine or?
Yeah. Oh yeah. It's I think what I was seeing was right before the president came out and has been touting this drug as the greatest thing in medicine. I'm like thinking, like, I'm like running through my head list. I'm like, I can think of a lot of things that are better than this. I actually was like following some studies online. Some people were taking it, and I was like, I'm gonna order some for the pharmacy. It was already sold out, like, through our distributors. So we get our drugs, like we buy them. There's like Cardinal, McKesson, Amerisource. There's a handful of drug distributors around the country, and that's where we get our generic drugs from. And they were already sold out through them, and they're starting to get it back in. And it's the same thing with hand sanitizer, face mask, gloves. We're starting to slowly see the supply chain catch back up, but we're still not able to get it. And so I think pretty much what I did, like the way I interpreted the research and the more stuff that's come out, it's not giving the benefit for patients with COVID-19 that people thought that the president is touting that does. And so a lot of states have released guidelines saying, like, doctors, don't write these prescriptions for yourselves or your family members. Don't hoard them. I mean, from what I've seen, I've seen reports online, some doctors around the country are essentially hoarding it like it's toilet paper, like it's their toilet paper. So, they're releasing guidelines around the country where states are saying, if a doctor writes this, report them to the medical board. And Tennessee's not gone that far yet, but they've also released guidelines pretty much saying, this needs to only be for patients that have immunosuppressed diseases or are COVID-19 positive. And so the first thing I did was I pretty much I ran a report on my computer. I was like, okay, how much of this drug do I dispense a month, and how much do I have? And do I have enough for my patients that actually get it? And I've actually talked to a few of them since then, because they've called and they've expressed concern about not being able to get it. And I tell them, I say, no, I say, you're fine. I say, you've been on this forever. You're going to have it. Whether I said, I will move heaven and earth and make sure you have this drug, because that's what I signed up to do, is to take care of those people.
So that's really good to hear. Is that like a standard of care for pharmacists to say, hey, look, I'm realizing there's going to be national shortages of this drug. Let me look at my patient list and kind of do some proactive kind of helping my patients and making sure that we're going to be able to serve those people that depend on that drug for essentially their livelihood in the case of autoimmune disorders, right?
Oh yeah, especially for the benefit of working in a small town where you get to know these people so well. You've developed these relationships with them, and that's why all of us get into being pharmacists. Is we like developing those relationships and knowing that people would trust us and rely on us for that. And I think the problem we see drug shortages ebb and flow. It's unfortunately a common occurrence, and so it's hard to predict. So a lot of times whenever a drug shortage does happen, we figure out about it after the fact. And so but we're always making sure people are taken care of. A big thing, last year was the generic Zantac or ranitidine. It's used for stomach acid, and it all got recalled. It actually, just as of 2 days ago, there was a nationwide recall of all of it, period. And so we made sure to get our patients switched over to other drugs. That way, their therapy didn't stop. So, we either make sure we've got enough of the drug in stock, something like hydroxychloroquine, where there isn't an alternative, to make sure we've got it in stock for those people, or if there is a therapy that we can change somebody to, that we do that. That way their care doesn't get disrupted. So, and there's been some states that have actually been like, they passed laws to where pharmacists can do that without contacting the doctor. If it's a drug within the same class where they're essentially brother and sister, just changing them to an equivalent dose. And so I'd like to see Tennessee push forward with that, because it does save us time, save doctors time, and make sure those patients don't have a lapse in care.
Yeah, absolutely. Have you seen as we're moving forward, people are at home, there are going to be lots of other things, right? Lots of other things. You're at home, you decide to work around the house, you smash fingers hammering something, you do whatever. Have you seen an uptick in anything else that might seem strange, that's kind of out of the normal?
I've not actually. I've not. No. That would not shock me though, because I have seen a lot of people, working on those home projects where they're at home now. So I think that unfortunately that might be coming. But where I do work more in kind of the mountains, you do usually see some backwoods medicine, and so people don't necessarily come in all the time whenever they do hurt themselves, unfortunately. And it's usually kind of the interesting thing about my job is, you think about how many questions, I get a day, and it's easy to get fatigued off that. But then you get those ones where it's like, I've had this going on for 3 years. I'm like, why don't you, I ask them why don't they go to the doctor, and the answer is usually the same. It's like, I don't have insurance. So, but it's I think that is something in Tennessee you see, especially where people, and maybe just in the South, people don't want to be a bother, and they don't want to go to the doctor and inconvenience them over something that really, 3 months ago, if they had, gone to the doctor, it would have saved them, a lot of money, a lot of, it would have, helped their mental health, their livelihood, their lifespan.
So on the note of, and by the way, hello, Kim, hello, Curtis. If you all have a question, please,
hey guys,
post it there and we'll ask it. So on the note of mental health, I've seen some maybe unrelated mental health drug supply questions come across. Most of those have been related to, hey, I can't afford a critical mental health drug that I have because I've been laid off, or hey, I can't get access to this drug because for some other reason. Have you seen any problems in the drug supply, or do you have any recommendations to those people that all of a sudden can't afford their maybe mental health medications or other medications because they've been laid off?
The big thing is taking it always depends on what the drug is, because especially for a lot of mental health drugs are or some of the newer ones, if they are brand name, most likely the doctor can usually get a hold of a drug rep and get free samples. That's something I always recommend to my patients, especially for insulin. That's my big one, like insulin and inhalers. If I've got an older patient, if they're in the donut hole with Medicare and their inhalers this outrageous amount of money, and I know they can't afford that, I always tell them, I say, get in touch with the doctor. Or also, in the past, I've helped people fill out patient assistance programs to where companies will send them the drug for free. And then also, I think it's here in Knoxville, UT Hospital. I think they partnered with the Dispensary of Hope out of Nashville to do it's essentially a pharmacy for people that don't have access to that. And we've got that actually up in Johnson City as well. And I worked there for a little bit in pharmacy school, and it's they provide drugs to people that can't afford them. So kind of being cognizant of that, if you're about to run out of medicine and there is a concern there that you're not going to be able to afford that, if you're not going to be able to afford it whenever you do need a refill, is taking that step to reach out to the doctor, reach out to the pharmacy. And there are and then there's also apps like GoodRx, which there's commercials for it everywhere. I have problems with it, but that being said, I always tell patients I understand why they use it, and I always encourage them to use it. It's more of it's a problem I have with it, of how they how they bill us and how they make money by data mining off patients, and then they can sell that data to, it's kind of scary, they could sell that data to insurance companies, and then the premiums could get adjusted based on that. Someone's, a insurance company will be able to ascertain, oh, okay, I'm pretty sure this is who this person is. These are the drugs they take. This is the disease they have. They're going to be more expensive to cover, so I can raise their premiums. So the problems that I have with GoodRx are never patient focused. They're on the back end. And so I always encourage people to look into using that because it will save them money.
Gotcha. So thinking about what you've seen so far during, being a pharmacist in the pandemic, and also, I mean, you and I have talked about there are a lot of things that we need to change in government.
Yeah.
Around a bunch of things, but especially around prescription drugs.
Yes.
And how we handle that. What do you see that should be like our very first 1-2 steps coming out of this pandemic on what we should has it rearranged any priorities for reform in the especially prescription drug area? Should we be talking about national or state stockpiles of different drugs? Should we be talking about I mean, I'll just go ahead and tell you, I want to talk about lowering the cost of prescription drugs, of course, but what should we be talking about coming out of this? Have we learned anything new that rearranged priorities?
So have we learned anything new? Yes. How are we gonna is our government going to act on that? That is I'm not sure of. I actually, and I hadn't even thought about the stockpiling thing. It's a good idea. My first thought is, though, if you do stockpile those things, how do you ensure that you're rotating it? So if something does happen again, you don't just have a bunch of expired medications. And my thought is to rotate those out and send them to pharmacies, and maybe even I was talking about the Dispensary of Hope in Nashville or Memphis, I'm sorry, and having these state-run pharmacies that provide medicine to people in major metropolitan areas and rotating medicine from the stockpile out of those, I think is an option. I've seen priority-wise, I think for pharmacists, there's my opinion differs, I think, from the American Pharmacists Association, the APHA, in that they've been advocating for provider status for pharmacists for a long time for a very good reason. For billing for us right now, I'm a doctor, but I can only, if I wanted to bill Medicare, for vaccinations, for wellness screenings for patients, I'd be able to, I could bill at a rate of about a quarter of what it should be, just because we're not recognized as providers. So that's always been their focus. And that's not a bad focus to have, but it's almost been a laser focus whenever there have been other issues, primarily, with, you talked about, the cost of prescription drugs. Something I always, tell my patients whenever because whenever their medicine is expensive, I always tell them, I always tell them, I'm like, no, I completely agree with you. They're like, it should be free. I'm like, no, I agree with you. It's like, I can't do anything about it. And I get that frustration sometimes because I have those patients that, they can't afford their medicine, and I can't do anything about it because I'm at the mercy of the insurance companies. So one thing we have been pushing for, and we've done a very good job actually pushing for it here in Tennessee, has been PBM reform. And I know me and you talked about it a few months ago. Whenever we met up downtown, was the pharmacy benefit managers. So it was, I don't know what deal got struck to get this done, but you suddenly had insurance companies like Blue Cross Blue Shield outsourcing their prescription drug management to a company like Optum or Caremark, who is owned by CVS. So we have these middlemen, and they're the ones that are setting these prices for the pharmacies, but they're also billing they're getting kickbacks from the drug manufacturers, and they're also getting paid by the insurance company. So, and I think the example I used whenever me and you were talking about it was like, let's say you come to my pharmacy, Matt, and you've got a prescription for a drug. Let's say it's $10. So I run the prescription through, and the insurance company, or I run the prescription through, and and all this processing happens immediately. So it goes to the benefit manager, the PBM, and they come back to me and they say, okay, because you're not in network, we're going to give you $5 for that. Now, I don't want to lose you as a patient. I like you. You're cool. I like spending time with you. You're a customer. I don't want to lose. I care about my patients. I don't want to lose you. I'm like, okay, that's fine. So they give me $5 for it. But then they turn around and they tell the insurance company, oh, here's that bill. It was $10. So they made $5. Turns out they've also got the drug that you wanted. It wasn't on formulary, but I got to change to one that was. Turns out it was on their formulary because the drug manufacturer is also giving them a kickback. So they get the $10 and then maybe $2 or whatever reimbursement from the drug manufacturers. They're making off. They're making money hand over fist. And the problem is, I mean, that's a huge problem. And on top of that, you have companies like Walgreens and CVS that own these pharmacy benefit managers. So I lose patients on a regular basis to Walgreens or CVS because the drugs are cheaper there, because they own the pharmacy, because they own the company that sets the prices, so they can charge themselves a better rate. See it with Express Scripts too, because they have a mail order pharmacy and patients are able to go there and get their drugs for free. So that has been a focus of the Tennessee Pharmacists Association in the last few years. It's one we just got a massive bill passed. I think with everything happening right now, I need to catch up and see what's happened with it, but that's been a major focus of us, is trying to reform pharmacy benefit managers in Tennessee to where there's more transparency, because right now we don't know how much money they make. There's no auditing. Like even like TennCare, they have a PBM and it's Optum. We don't know how much money they make though. So I think it was either West Virginia or Ohio, they brought that PBM in state and they ran it themselves and they saved millions of dollars. It was over a year. It was insane. So doing stuff like that, especially for a state-run insurance plan, mm-hmm. the drugs aspect of that should not be managed by a private company without any oversight.
Is that so if a person's not on TennCare, but they're on if they're like under Care Kids or something, or is it mm-hmm. still run through that same Optum PBM?
I don't know. I'm not sure. I know that TennCare and CoverRx both switched to Optum this year, and so I want to say yes, but I'm not sure, to be honest. But it is more likely than not, it is administered by a PBM, because most insurance plans, their drug the prescription pricing aspect of it is including Medicare. So,
gotcha. So we had one more question here.
Yeah.
Are there anything, and I think we covered part of it at the very beginning, but is there anything especially related to diabetes, cancer, Crohn's, any medications there that are being delayed or unavailable?
With diabetes specifically, it's not the medication, but it's the supplies. So specifically your alcohol pads. So something that has changed for us, we're moving them behind the counter, because unfortunately with panic buying, people are buying stuff like that. And, I don't know why they're buying it. So, it could be because they have diabetes and they're worried. So it's not my place to judge them, but we've moved those behind the counter. So that's been the big thing. It's like, whenever I think of like the kind of what's going on right now, I think diabetes. With cancer, a lot of times with the chemotherapy drugs, those are done in a hospital setting or an infusion setting, and so I don't deal with that type of stuff. But I still worry about those people, because one of my friends actually has cancer, and so I worry about that and making sure that they're safe, and having access to things like gloves and face masks. So mm-hmm. kind of similar to diabetes, it being a supply thing. But really with drug shortages would be people with asthma or chronic obstructive pulmonary disease, COPD. So those are whenever I think about like the people that I'm worried about having access to stuff, the ones that I deal with on a day-to-day basis, it's those two, especially in Tennessee with the rates of smoking that we see here, and with people that used to work in coal mines. You do see a lot of older people with COPD and not having access to inhalers, especially like albuterol inhalers, which are we call them rescue inhalers. It's pretty much you carry it in your car, your purse, use it in an emergency. And a lot of, they're being prescribed right now because people are short of breath if they've got COVID-19, or if they're panicking and think they have COVID-19. So, we're worried about that, and having those for my patients that I know desperately need them has been on the back of my mind, because those have been hard to get lately too.
Well, that's all the questions that we have. So I think we'll go ahead and wrap up. If you are a person out there that needs any help right now, any supplies, anything, and you're unable to get it, please send us a message. We're working with a couple nonprofits to do some mutual aid in the community. So please send us a message and we'll help connect you up with those people. If you're a person that wants to volunteer, it can be for our campaign. It can be for one of these other nonprofits that's out doing mutual aid, helping the community. Also send us a message. We'll get you hooked up, get you, set up to help do some stuff. If you are just looking for something to do at home and you want to be able to make some phone calls, check on people, do wellness checks, send us a message and we'll definitely get you hooked up. Thank you again, Tyler. Thanks, man, for
anytime.
joining us. I know that it seems like a lot of people appreciated this.
That's great. I mean, it's healthcare policy. It's got a special place in my heart, especially seeing what the lack of care can do for people. I put a lot of it on myself. It's because I do worry about those people, and that's kind of, I think that's the biggest lesson I think we need to take from this is, or like not having access to care, what it does, but also the end. I'm trying not to soapbox too much, or this is why I'm wearing my West Wing shirt, is like doing like a Jed Bartlett style speech, but like how important it is for people to have that access to care, but also having that access before it's needed, like having a stockpile of drugs or supplies or anything.
Awesome. All right. Thanks again. Thanks everybody for watching.